Good morning, everyone. I will be covering breast cancer oncology for primary care providers. As you know, I'm Dr. Carmen Calva. I'm a breast medical oncologist at the University of Miami Sylvester Comprehensive Cancer Center. I'm also the medical co-director for the Survivorship program, associate director for community outreach, and I'm an associate professor of clinical medicine at the University of Miami Miller School of Medicine. So I'm going to focus today on working with the diversity and uniqueness of the South Florida community and what does that entail, breast health and breast cancer for PCPs, how to care for breast cancer survivors, and available resources to support the care you provide. So let's focus on the first one, working with the diversity and uniqueness of the South Florida community, reviewing some of the breast cancer statistics and breast cancer demographics. Each year, American Cancer Society estimates the number of new cancer cases and deaths in the United States. And as I'm updating my slides every year, I notice that there is a significant increase in the number of new cases. So in 2023, the estimate is that the new cases of breast cancer will exceed the 300,000, with the 297 and 790 being women, and then 2,800 men will be having a new diagnosis of breast cancer. Unfortunately, we're still losing more than 40,000 patients due to breast cancer every year. So as you know, for every 100 women diagnosed with breast cancer, there is one man. And as you can see, the statistics unfortunately follow. In Florida, they estimate 22,000 new cases of breast cancer for 2023. So what are the probabilities of developing invasive breast cancer depending on the age? We hear that breast cancer should not happen in young individuals. And we hear many times patients being told you're too young to have breast cancer. Unfortunately, that's not a true statement. You can be very young and have breast cancer or very old and have breast cancer. Just the age does not make a cancer diagnosis impossible or possible. So from birth to 49, the likelihood of getting breast cancer in a lifetime is 1 in 48. And as you move on to different decades in life, the 50 to 59 is 1 in 41, the 60 to 69 is 1 in 28, the 70 and older is 1 in 14, and then birth to that is the 1 in 8 chance that you hear on usual statistics about breast cancer when the question is asked, what's the lifetime risk of an individual with average risk to develop breast cancer? And that's in general 12% or so. So when you look at the demographics in the United States, they're changing and Florida is directly impacted. So this graph shows you the rate of new breast cancer by race and ethnicity in female, and the rate is per 100,000 women. So as you can see, the white non-Hispanic, the Black non-Hispanic, the American Indian and Alaskan, Asian and Pacific, and then the Hispanics. So the rates of newly diagnosed breast cancer are depicted here, but the outcomes are not following the same pattern. So this graph also shows you the cancer profile by race and ethnicity from 2015 to 2019. And the US percentage versus the Florida percentage, I'm not gonna go on every single one of them, but you can look that we have a high proportion of Black patients in Florida, foreign-born. We have a larger proportion than in US in general for Hispanics. The non-Hispanics are less than the general United States distribution, and the white are just about the same. So what are the facts depicted in this picture? Well, this is just showing that in 2022, the estimated breast cancer number of new cases was 287,850. And for men, there were about 2,700. So you saw the 2023 estimates, there were 2,800 for men. Now, in that 300 plus thousand that I showed you in the previous one, there's the DCIS cases that is the non-invasive, and it's included. Here you see them depicted separately, and that's about 51,000 per cases. The lifetime risk, as you can see on the left side, it shows you the cartoon with 8 silhouettes, and 1 in 8 has breast cancer. And unfortunately, when you look at the trends in 1975, there are a lot more women depicted, or women and men depicted in that graphic, with a 1 in 11 chance of developing breast cancer in a lifetime in 1975. So that shows you how the lifetime risk has gone up from 9% roughly to 12% roughly from 1975 to 2022. More facts about breast cancer, unfortunately, is the second leading cause of cancer death in women. And as we discussed, more than 40,000 die due to breast cancer every year. Every 13 minutes, a woman dies from breast cancer. The racial disparities are significant. Despite a similar incidence, mortality from breast cancer among Black women is 41% higher compared to white women, according to the ACS in 2022. So progress in breast cancer mortality reduction has been slowed in recent years. The mortality rate was decreased by about 1.9% annually between 1998 and 2013. Annual declines have slowed to 1.1% between 2013 and 2019. While the breast cancer mortality rate has declined, the number of women and men who die each year is rising. Why? Because the total number of new cases is up and will continue to rise as the aging population grows. Let's go to breast health and breast cancer care for primary care physicians. Your role is so important, and the partnership that we have with the primary care physicians is essential for the well-being of our patients, their families, our community, and beyond. So I'm going to cover breast cancer risk factors and genetic testing, breast images, when, which modality for whom, signs and symptoms of breast cancer, types and stages of breast cancer, and treatment in general. What are the risk factors? We talk about modifiable and non-modifiable risk factors. There's some things you have control over and some you don't. When people are talking about genetic mutations, they only explain about 5 to 10%, and maybe according to the new statistics, they can go up to 15% of the new cases. However, there are other risk factors that are modifiable that we actually can do something about. But let's learn which are the risk factors. So getting older, long menstrual history, having dense breast, personal history of breast cancer or certain non-cancerous breast diseases, a family history of breast or ovarian cancer with or without the genetic mutation, previous treatment using chest wall radiation, never having children, being over 30 years at first full-term pregnancy, use of hormonal contraceptives for many, many years, or high natural levels of sex hormones, use of combined postmenopausal hormone replacement therapy for several years, being overweight or obese, that's true for menopausal patients, not being physically active, and drinking alcohol. So, like I mentioned, cancers with inherited mutations are depicted in this picture. And you can see that depending on the type, the likelihood of finding a genetic mutation in that individual is higher, and then it goes down as we go down the green bars. So the ovarian cancer patients have a 19% likelihood of finding a genetic mutation. And then you go down with the stomach, breast, prostate, lung. Even the CNS, the glioblastoma or the glioma, head and neck cancers, endometrial cancer, even lung cancer is recently described to be associated with genetic mutations. Kidney cancer, acute myeloid leukemia, and other cancers. When you look at the breast cancers, in that proportion that I mentioned that is explained by a germline genetic mutation, they're not only the BRCA1 and the BRCA2 that I think most of us are now familiar with. There is a smaller proportion of other genes, and that list, it's on the pie depicted there with some of the genes that you may have heard about, the PALB2, the CHEK2, the TP53, the RET1, other genes. Those are increasingly recognized to be associated with breast cancers and other cancers. So just to be clear about the germline mutation versus the somatic mutation. The germline one is the mutation that germline is solely inherited from an affected parent. All bodies, cells carry that mutation, and it's passed down the generations. So half of the gametes carry the mutation, and the chance of one parent transmitting it to the sibling, to the children, and it doesn't matter if it's female or a male child, it's a 50-50. For the somatic mutation, those are mutations sporadically occurring in a body cell, and we find them in tumor cells to carry the certain mutations. Those mutations will not be passed on into gametes, and those are not something that we recommend family members to be tested for. So you hear the somatic mutations in the context of someone having next generation sequencing performed on their tumors or on their blood that has circulating tumors. And you hear the germline mutation results for someone that says, I had a BRCA test done. That's when you hear this. So who should consider genetic testing? Well, NCCN and other guidelines have recently updated their recommendations of performing genetic testing or considering genetic testing for all patients with a solid cancer tumor diagnosis. And why is that? Because if you find a genetic mutation, it has so many implications on the way you treat that individual cancer, and also on the way you perform high-risk surveillance for other cancers that the patient can be at risk, and also for cascade testing in first-degree relatives of the family members. So with the cost of tests going down from thousands of dollars to just few hundreds, and the amount of information received from that test, it just makes sense that anyone with a solid cancer tumor diagnosis is offered germline testing. There are more precise recommendations to follow, especially the older way to look at things was to really make sure the checklist was, all the criteria and the checklist were met, and the patient may or may have not qualified for germline testing. But that has gotten simpler now, and I think, it's important to have these criteria that you can refer to, but in general, keep in mind significant family history, unusual cases of a specific cancer type, like breast cancer in a man, that screams for genetic testing. The presence of birth defects that are known to be associated with inherited cancer syndromes, being a member of a racial or ethnic group that is known to have an increased risk of having a certain inherited cancer susceptibility syndrome and having one or more of the above feature as well. Recent evidence then suggests, like I just told you, universal genetic testing for all diagnosed with a solid tumor makes sense. Going further to other criteria, cancer diagnosed at unusual young age, several different types of cancer in the same person, cancer in both organs in a set of pair organs, such as both kidney or breast, several first-degree relatives, family members with breast and ovarian, family members with colon cancer and endometrial cancer, several family members with cancer, Ashkenazi Jewish descent. When you look at this graph, it just shows the possible moderate penetrance genes, and they're listed here. So you are going to hear more and more about these genes associated with cancer, breast cancer in particular in this case. And I think it's important for us to just remember that the genetic testing that is looking at a small panel, gene panel now, can be updated to include a larger panel, especially when the suspicion that something in that family is going on is there. So there are genes that are falling into the high penetrance with a more than 5-fold increased risk, and those are the BRCA1, BRCA2, TP53, CDH1, PTEN, STIC11. And then when you look at the PALB2 gene, which is behaving like a BRCA2, has a 4 to 8-fold increased risk. And when you look at the ATM and the CHEK2 again in red, there's a 2 to 5-fold increased risk. However, in some families, it's a much higher risk. And I've seen families that were initially tested for the BRCA1 and 2, and were found to be negative. And then upon retesting, when the CHEK2 was discovered, that family was found to be a carrier for the CHEK2 mutation, which explained then the incidence of breast cancer in that family. The risk and how you counsel the patient regarding their lifetime risk about each cancer that are associated with that specific gene, it's a complicated matter, and that's why we recommend that everyone with a genetic mutation is seen by a genetic counselor, because the risk is not the same. You have to take into account the particular gene, but also the individual risk factors and the family history and the pedigree and all that. So the risk also changes with age. So what makes sense when you're diagnosed at a young age, it's not exactly the same when you're in your 60s. Bilateral mastectomies to have risk reduction are, highly recommended in a young age, but as we move on and the woman becomes older and older, potentially it could make less sense to have bilateral mastectomies. So just increased surveillance and potentially even taking a medication to reduce the risk is what that individual potentially could benefit more from. So what are the recommendations for imaging, right? And how do you assess one's risk? The average risk was 1 in 12. And for that individual patient, starting a mammogram at age 40 and going every year, it's all she needs. But there is so much more when it comes to personalize the risk of an individual. So several risk assessment tools based on personal family risk factors, including other types of cancer, are developed. Types of breast tissue, if it's fatty or dense, matters. Women of African and Ashkenazi Jewish descent should undergo risk assessment at age 30 to determine if they should begin early screening. You don't want to start screening a patient with a BRCA gene mutation at age 40. You're going to be like about a decade late. Women of Bahamian descent have high incidence of BRCA mutations, so the same applies to them as well. What are the imaging guidelines? So as you can see here, several organizations are making recommendations. Sometimes their consensus is 100%, but many times it's not. So when to start, when to stop, and how frequently you should do it is still a matter of debate. The US PSTF, which is the task force, recommended 50 as the start age, and then a personal choice for the decade before with a stopping age of 74 and going every other year. The American College of Surgeons recommend 45 with a personal choice in between 40 to 44. And you don't stop unless the life expectancy is less than 10 years. You could go annual or biannually. And the American College of Gynecology recommends to start at 40, discuss the 75 age limit, and then go annually throughout. And the American College of Radiology and the Society of Breast Imaging recommends to start at 40, go annually as long as the life expectancy is somewhere in 5 to 7 years range. This is what I told you, the average risk of 12% or so. That's when you start at 40 and you go yearly. If the patient has a family relative, first degree, that is diagnosed at an age less than 50, the recommendation is to start 10 years younger than the age that the person was diagnosed, so no earlier than 30 to begin a mammogram. And this was found to maximize mortality reduction, life years gain, and it's embraced as standard recommendation. The intermediate risk to develop breast cancer is now above the 12%, but below the 20% when the high risk starts. And what would gain you to have that risk? It's dense breast, it's personal history of breast cancer, biopsies with high-risk lesions, a personal history of ADH, which is atypical ductal hyperplasia, atypical lobular hyperplasia, LCIS, strong family history. Some of these may benefit from contrast-enhanced mammography when they reach almost 20%. And if the risk is over 20%, that's when we are talking about high risk for developing breast cancer. And those are the contexts of genetic mutations, very strong family history, chest wall radiation between the age of 10 and 30. The recommendations then are annual mammogram to start at age 25 to 30, an annual MRI to start at age 25, and an ultrasound only if MRI is contraindicated. This does not add to the diagnosis and it has a decreased sensitivity. In the context of radiation to the chest wall, the recommendation is to start 8 years after treatment completion, but not earlier than 25. So that concludes our who's at risk, how much risk there is for one particular individual, and how do you do surveillance depending on the risk. Now I'm going to move on to the types of breast cancer. The most common type is invasive ductal carcinoma, with the second most common being invasive lobular carcinoma. They're actually pretty different. So as you can see here, the invasive cancer cells are breaking through the duct, and then the invasive lobular originates in the lobule. There are several other subtypes. Ductal carcinoma in situ, it's also called DCIS. It's also called intraductal carcinoma. It's non-invasive breast cancer, where abnormal cells have not spread through the ducts into surrounding breast tissue, has not yet spread outside of the breast, and may become invasive breast cancer. And unfortunately, as much as a non-invasive cancer, ductal carcinoma in situ is, it gets treated pretty much just like early stage breast cancer. Lobular carcinoma in situ, on another side, is abnormal cell growth starting in the lobules, non-considered true cancer because it's not likely to spread to surrounding tissues. And it's really treated as a high-risk lesion and is not treated as early-stage breast cancer. So ductal carcinoma in situ and lobular carcinoma in situ, they're both non-invasive, but lobular carcinoma in situ is no longer considered a type of breast cancer. It's a high-risk lesion. So it's an indicator that the woman may be more likely to develop invasive breast cancer in either one of the breasts, not only in the affected breast. More about the invasive ductal carcinoma. Known as an infiltrating ductal carcinoma is the most common type. It starts in the ducts. It may also spread to other parts of the body. And about 8 out of 10 invasive cancers are invasive ductal. The invasive lobular or infiltrating lobular carcinoma starts in the lobules, can spread to other parts of the body. They're invasive, right? Maybe harder to detect with mammography, and approximately 1 in 10 breast cancers are invasive lobular. In the types of breast cancer, I'm going to mention a couple of them that it shouldn't be missed, and I think the primary care physicians are the ones that potentially can be facing the initial complaints. So I want everybody to be aware that about 1 to 3% of all breast cancers are this type, inflammatory breast cancer. It's a very aggressive type. It happened in young age, it happened in dark skin and white skin. Sometimes it's really hard to see the changes, especially in the dark skin. A lump or a tumor is not always detected. It does present like a swollen, almost infected, inflamed breast. And if you have seen how a mastitis looks, this looks similarly. Now, if you can't find reasons why a woman should have mastitis, it's not breastfeeding, and even if she was, it's potentially that she has a mastitis, but in the back of the mind, inflammatory breast cancer has to be there. And the symptoms may consist of inflammation, redness, pitted appearance, itchiness, or tenderness, and it really looks like an orange pill. In this situation, recommendation is to really proceed with 2 weeks of antibiotics, and if there is no improvement, no significant improvement, a diagnosis should be made through a punch biopsy, meaning that you go with a large needle through the skin, because as I said, it doesn't form a mass, and on imaging, it may be not visible. So the diagnosis is made through the punch biopsy. The Paget disease, it's a rare type of breast cancer, almost as rare as the inflammatory breast cancer. Cancer starts in the breast ducts, then it spreads to the skin of the nipple and areola. It's usually associated with ductal carcinoma in situ or the invasive ductal carcinoma. And the symptoms may consist of the nipple and areola being crusted, scaly, red, bleeding, oozing, burning, or itching. It's just around. So it's visible on the skin. It just needs to be taken into account in the differential diagnosis, recognized, and then appropriately refer and treat. So what are the stages? Many patients come and they don't know the stage, and I really always want to tell them, as painful as sometimes it is, I think being honest with the patients is important because you set up the expectations, and if you exceed them, great, but if you don't exceed them, at least the expectation is set up correctly. So the stage 1 is a smaller tumor, less than 2 centimeters, just in the breast, as you can see there. And on stage 2, you have larger tumors and 1 to 3 nodes. One or the other or both. And then in stage 3, the number of nodes, it's more than 3, and the tumors are usually larger. So those are the locally advanced breast cancer. And in stage 4 is when the cancer spreads outside of the breast distantly. So the treatment modalities and the intent: for stage 0 to 3, we go for curative intent treatment. For stage 4, treatment is given with palliative intent, keeping in mind that selective candidates can achieve durable remissions and potentially cures. I think this is essential to set it up on day 1 so the patient doesn't feel defeated. And the truth is that there is about 5% of the patients with stage 4 that are potentially cured. And I think that number is going to go much higher in the very near future. And we see those patients and we have them in the clinic. So I always leave that door open, and hope is very important in treating breast cancer, as in anything else. So the systemic therapies, when you hear that patient is on systemic treatment, that can mean anything from chemotherapy to hormonal treatment, targeted therapy, immunotherapy, or a clinical trial. You see that clinical trials are on every one of the treatment modalities, because through clinical trials and research participation, we actually move the needle. And the mortality from breast cancer dropped in the last 3 decades by 43%. So that's a significant improvement. The fact that we're losing 43,000 women to breast cancer and men, it's not because the mortality impact is not there from the treatments and early interventions and better screening and clinical trials, but it's because the number of cases has gone up. So when you look at the breast surgery, a lot of changes there. We no longer go radically to remove most nodes and remove most breast tissue. We have gotten significantly better in downstaging with systemic treatments, and then offering all patients that can benefit breast conservation, meaning a lumpectomy, which is usually followed by radiation therapy. Mastectomy is removal of the breast. Sentinel lymph node is just testing the nodes that the initial station, and then if they're not affected, usually the axillary lymph node dissection with removal of the rest of the nodes doesn't need to happen. In the breast reconstruction, a lot of progress was made with implant reconstruction, but there is also autologous reconstruction using the patient's own tissue, and it can be done right initially at the time of the breast oncological surgery, but it can also be done either a little later or much later. So that's the immediate delayed or the immediate reconstruction. And in terms of radiation, also significant progress is made with the partial breast irradiation, the whole breast radiation, and then we have proton therapy and also clinical trials. So we are at how to care for breast cancer survivors topic, which is obviously one of the main areas where we overlap in caring for our survivors. And I want to make sure that the exchange of information is amazing and the dialogue is ongoing. So there are survivorship challenges, there are survivorship care models, there are survivorship goals with surveillance monitoring for long-term toxicity, as well as late toxicities, prevention, and care coordination. So what's the definition of survivor? Well, acute survivorship starts at diagnosis and ends when initial treatment is complete. And it focuses on treating the cancer and minimizing or managing side effects. And then there's the transitional and extended survivorship, which spans the months and the years following the treatment. Patient could be alive and with no evidence of disease, in remission, and may or may not be on maintenance therapy. And then you have the long-term or the permanent survivor, where years have passed following the initial diagnosis and treatment, maybe cancer-free, with living just with the long-term sequelae of cancer treatment, or experiencing a recurrence or treatment-related cancers. So the ASCO's guiding principles are the survivorship care should begin at the time of cancer diagnosis, and starting early allows the patient oncologist and primary care physician to lay the groundwork for better continuity of care, both during and after treatment. At the time of the diagnosis, the oncologist should identify and communicate with the patient primary care or establish one if necessary, and recommend continued follow-up with their PCP that occurs early in the cancer diagnosis and consistently throughout treatment to ensure ongoing preventative care and managing of comorbidities. And then the principles of self-care and self-monitoring should be utilized to empower patients to have active engagement in their follow-up care. I call survivorship the gift that keeps on giving. As you see here, I created this slide with the individual in the center as a patient-centered model, and with all the side effects of the cancer and the cancer treatment just surrounding the individual. On the larger side, I created the circle of friends, as we call it, with all the specialists that we need to employ to really address all the side effects that the cancer and the cancer treatment bring on. And as you can see, the PCP and the oncologist are working hand in hand, and then the rest of the disciplines with the psychologist, psychiatry, neuro-oncology, cardio-oncology, fertility and preservation, sex therapist, integrative medicine, cancer rehab, palliative care, social worker, exercise physiology, research, genetics, all being hand in hand, working together to really assure best survivorship. So it does take a village, is not just a slogan, is the reality of it. And we do have the village at Sylvester. And with your help, we can create best survivorship for our patients. So what's life as a survivor? And thankfully, I don't know it on firsthand, but I hear it from my patients and I see it every day. For some, consequences are minimal and they return to normal life, but many do experience physical and or psychosocial effect of cancer and its treatment. And at least 50% of the survivors experience some late effects on cancer treatment, such as depression, pain, fatigue. So the standards for survivorship care include assessment and managing of physical and psychosocial long-term and late effects of breast cancer and breast treatment. And the previous graph shows you all these side effects and consequences of cancer and cancer treatment. In 2016, which is like 7 years now ago, ACS and ASCO released the breast cancer survivorship care guideline to provide recommendation to assist PCPs and other clinicians in the care of female adult survivors of breast cancer. And their recommendations were to make sure that the surveillance for breast cancer recurrence happened with a history and physical, screening for a local recurrence and a new breast cancer primary, laboratory testing, and watching for signs of recurrence. There is also a recommendation for risk evaluation, genetic counseling. I told you that we learn more about genetics, we learn more about new developments in a family or a family history, and appropriate genetic testing and counseling should happen throughout. Endocrine treatment evaluation and screening for another primary cancer. So what are the current challenges? Well, there is inconsistencies in access to PCP and also PCP awareness for cancer-related issues. Delays in optimal PCP care, suboptimal use of oncologist time with internal medicine-related issues, delays in access to oncology, overuse or underuse of services, overuse or underuse of internal medicine subspecialties, no consistent appropriate screening or immunization, and no consistent appropriate management of comorbidities. The psychosocial effects and the physical effects, as you can see here, could fill not one page, but pages. And the psychosocial effect that are the one that the patient complain the most are really the fear of recurrence, which is about 70% of survivors. Almost 20% meet criteria for PTSD. And then there is everything else in between, with positive gratitude empowerment, going to increase unemployment rate, and many experiencing distress or a combination of anxiety, depression, fear of recurrence, PTSD, and cognitive dysfunction, fatigue, just a difficult reintegration in the day-to-day routine that they have prior to cancer diagnosis. And, you know, the physical effects of cancer and cancer treatment are not making the patient feel the greatest. So they're intricated with the psychosocial effect. And more than a third of them report at least one unmet need, which is either pain, musculoskeletal issues, fatigue, lymphedema, premature menopause, cognitive dysfunction, and sexual dysfunction. So what are the essential components of survivorship care? Well, it's prevention, like with lifestyle changes that can prevent new cancers and recurrent cancers. Surveillance for cancer spread, recurrence, or a second cancer. Intervention for consequences of cancer and its treatment. And then coordination between specialists and primary care providers. So I'm not going to go through every one of them, but I thought you should have a nice list with not only what can happen, but also what are the risk factors, how common or uncommon these long-term and late-term effects are, and what are the proven interventions that potentially can work. This is from a review of Survivorship on it in the New England Journal. You have the reference, and they go from chronic pain, infertility, early menopause, menopausal symptoms, chemotherapy-induced peripheral neuropathy, sexual dysfunction, metabolic syndrome, bone loss, fatigue, insomnia, cognitive dysfunction, heart failure, valvular damage and CAD, cardiac dysfunction. And then in the late effects, we see the osteoporotic fractures, uterine cancers associated with tamoxifen, potentially myelodysplastic syndrome and leukemia associated with alkylators, anthracyclines, and other chemo agents, and radiation, and sarcomas associated with radiation therapy. So how can you care for survivors in the best way that is feasible for all patients, caregivers, and the physicians and the healthcare providers involved? And the models have been tried out with pros and cons and preferences by either one of the components and the players, right? So there are models that are favored by the patients. There are models that potentially are favored by the healthcare providers, and what's that is favored by all. So there is the in-clinic care. There is the care provided by mid-level clinicians and disease site clinics. There's care provided by mid-level practitioners in separate clinics. There's shared provision of care, and there's care provided by multi-specialty clinics. And this need and depicting the way to develop a shared care model was started to be discussed in 2006. And we are so many years away from that, and we're still defining the best way to care for our survivors. And we learned that one model is not going to fit all, and every institution is going to find the way that works best for their patient population, their communities. But in general, a sample of shared care model shows here that the patient was initially known by the primary care physician, and that's the top left box. And when the cancer diagnosis happened, the oncologist becomes the main driver of the care. And from there on, and when the acute phase of the treatment has been completed, then the primary care physician resumes the main role, and the oncologist follows along. And then with the survivorship care going from the cancer diagnosis moment throughout the patient life. And with the roles in between PCP and oncologist alternating depending on what's the primary need of our patient, cancer care or consequences of cancer treatment and primary care, internal medicine issues. So what are the challenges? Well, primary care self-reported experience and comfort with providing aspects of cancer survivorship care is shown in this table. And the primary care self-reported practice pattern with provision of care for cancer survivors shows in the blue is the often, and then sometimes is in burgundy. Blue is rarely, and then orange is never, or brown is never. So you can see here how comfortable they are for providing care for our survivors, and what are the areas that we can improve upon by having a nice dialogue and working together. There's definitely the will from the primary care physicians, but there are also barriers that are identified. So the barriers are uncertainty about delegation of survivorship care responsibilities. Major is in blue, and then moderate barrier, but these are barriers that are either major or moderate. So as you can see, the uncertainty about delegation of roles is important, and that's why the dialogue is important. The lack of training. Patients seem to prefer to have their oncologists manage cancer-related issues. Lack of information about the patient's screening needs. Lack of adequate time to address cancer issues. Oncologist seems to prefer to manage cancer-related issues. Lack of information about the patient cancer history, and discomfort caring for patients with a history of cancer. So the discomfort doesn't seem to be a barrier. And the lack of information is also less of a barrier. So it's more of clarifying roles and training the primary care physicians to adequately know what the survivorship journey really entails, and what are the main needs of our survivors throughout their journey. So there is interest, and we want to leverage that. We want to work together to really develop this partnership. So the interest in information on survivorship with prompt update from oncology on important clinical events. Usually always is in brown, and then never is in blue. Access to survivorship care plan, follow the always, and usually it's the brown and the green. Access to cancer treatment summaries, the same. Prompt updates from oncology on important clinical events. Access to survivorship care plan, access to cancer treatment summary. Interventions to improve care coordination between PCPs and oncologists are important, because together we can provide the care that our survivors need to prevent recurrent or subsequent cancers, to screen for cancer spread, recurrence, or subsequent cancers, to assess their physical and psychosocial late effects, to intervene for their needs, to evaluate of concern related to employment, insurance, and disability, and to definitely build coordination between specialist and primary care provider to ensure that all the survivors' health needs are met. There is a group of cancer survivors defined by their age and diagnosis, and that's the adolescent and young adult, AYA, diagnosed in between age 15 and 39. Their needs are more unique, believe it or not, and mostly unmet. Why? Because this cancer happened at an age when you haven't finished your education, you haven't built a family, you haven't built a career. Many times your insurance is not even, chosen with the fear of a big diagnosis in mind. So all that create this unmet need for this AYA group of survivors. As you can see here, this is a list of unmet needs compared to the total needs. And it's long, and it can keep going. So what are the resources to support the care that you provide and we provide together? For the physical symptoms, we like to take the team approach, just like we take the team approach for everything else. We have a multidisciplinary approach to best manage the post-treatment physical symptoms. We have the physical medicine and rehabilitation with multiple indications for consultation, such as chronic pain, neuropathy, physical deconditioning after cancer treatment in conjunction with physical therapy, lymphedema. And they also have physical and occupational therapy, good when there's a physical limitation, injury, or chronic musculoskeletal issues that is impacting activities of the daily living. Can include upper and lower extremity strengthening, lymphedema massage, and when there's fatigue, physical activity is a good way to improve post-treatment fatigue. There is multidisciplinary approach for management of during or post-treatment physical symptoms that also include exercise physiology. It's good when there is no physical significant limitation or injury, and mild moderate reconditioning or exercise instruction is needed in the context of disease recovery. And palliative care with multiple indications, especially if cancer has recurred or if the symptoms and signs are deemed directly related to cancer, is treatment. And it could be pain that is visceral or whole body pain. It could be neuropathy. There's so many indications that the palliative care can be introduced upon, and it does not have to be at the end of one's life. It's actually the earlier you introduce it, the better. The psychosocial functioning, the stress of a cancer diagnosis and its treatment, and the impact of on self and family is profound. Remember, a survivorship and survivor diagnosis includes the caregivers and the community around and the family. Adjustment disorders are common, but patients may have varying degrees of depression, anxiety, fear of recurrence, and PTSD. General screening for mental health should occur at every visit. And if the need is not emergent, outpatient resources include psychiatry, psychology, and support groups. Sexual dysfunction is a significant downstream side effect of treatment. It's not only the physical impact of the cancer treatment, but also the psychosocial impact and emotional impact. So several changes occur that lead to sexual dysfunction, and consultations and consultants who may be of assistance are listed here with the sexual therapist, psychology, and we also have a unique program that is called Music, Menopause, Urogenital, Sexual Health, and Intimacy Program for patients that have cancer diagnosis and they have sexual dysfunction. Fertility concerns are also very important. It's mandatory to discuss fertility concerns before embarking on a curative intent treatment that potentially can render the patient infertile. An increasing number of younger women are being diagnosed with cancer, and we need to discuss fertility-sparing treatments upfront. Consultation should be considered with the infertility specialist. We have reproductive endocrinology and infertility as a subspecialty in OBGYN that treats infertility and oversees assisted reproductive technology, such as in vitro fertilization. Fertility specialists should be involved if it's unclear if the patient can get pregnant, if she has been trying to get pregnant but failed, she has known germline genetic mutations and wants to talk about how to reduce the risk in her baby. Many people don't know that that's an option, or she wants to bank eggs or embryos for later use. The financial burden is real. We also have a team approach. We have finance managers, social worker, case managers, and psychology to really help with the depression, anxiety that this brings on. The cancer support services is built with people that are each one of a kind. They make the best team. We utilize all these support services throughout the cancer journey, from the time of diagnosis and through life. We have arts in medicine, music therapy, oncology, massage, acupuncture, pet therapy, physical, pastoral care, social work, physical medicine and rehabilitation, palliative care, integrative medicine, Cancer Resource Center, and then the AOA program. So with that, I hope you have learned something today that you didn't know before, but one main thing, if you could, is that this partnership in between specialist and primary care physician is gold. Is gold not only to make our lives as healthcare providers better, but because it's the right thing to offer to our patients, their loved ones. And through our collaboration, their care will only get better. So thank you so much for your attention, and I'm happy to work with you. You can find me on the email ckalpha@med.miami.edu or on Twitter, Facebook, Instagram. It's all with my name, with the intention to be accessible, available, and to work with you all. Thank you.